Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm going to tell you about a patient I saw this week. He was a return patient, but I haven't seen him since January of 2023. And that was a one-time visit for, he said sciatica, but it turned out to be a cluneal nerve entrapment. It acted like sciatica, but it was really a trigger point in the QL. Anyway, I saw him. He said, I said, do you have sciatica again? And he said, no, whatever you did, that solved it. I've been good ever since. He said, but I got a different problem for you. And so it was a left shoulder pain, and he would have nerve symptoms and tingling going into the back of his hand in the radial nerve pathway. So I wanted to talk about that, talk a little bit about what I was thinking and what worked. To me, it sounded like definitely there's a radial nerve irritation. I palpated his forearm, but he already told me that he had shoulder things. So I was thinking, neurogenic thoracic outlet was very likely the problem. He has chronic neck problems. So to kind of sort it out, I palpated the forearm. Yes, he had some soreness in the extensors of the wrist, but then when I muscle tested his tricep, the left tricep, the affected side, was noticeably weaker. Not extremely weak, but noticeably. Like I could feel him have to kind of work a little harder on the muscle test. So I said, okay, very likely, not just a forearm thing. So then we run through the length testing for the pecs and the lats, and then we do the ruse test for neurogenic thoracic outlet, and fingers are tingling. So within seconds, 15, 20 seconds, his tingle came to the back of his hand, and I think he could feel a little bit in the forearm. Mostly he noticed the tingle when he was sitting at a desk working with his hands out front, and also at night. Difficult to find a position to sleep where his hand wouldn't tingle. So I assumed, okay, it acts a lot like it's a neurogenic thoracic outlet. And then I was feeling pec minor, a little bit tender, and yes, his pecs were noticeably tighter on the affected side. And I'm thinking, and he's already told me he has chronic neck issues, so let's feel the neck and let's see what's going on with the traps. And he had a very tender lower trapezius trigger point area. And if you're familiar with working on trigger points, you know that very often the lower trapezius can cause a nerve pain going down the arm, and I'll talk a little bit about why I think that happens. But that seemed to be the case. It was noticeably sore, tender in his left lower trapezius. His upper traps were super tight, and he has neck issues. I will throw out there that he also has been seeing doctors about tinnitus, ringing in the ears. He has a history in the military where he was doing communications. He feels like he got some damage to his hearing from that. The doctor confirmed he does have some hearing loss on one side, but he was having like a low level. He says like crickets sort of sound, and then pulsing. Lately, it's been pulsating. So they checked his blood pressure. They've done a brain scan. They did an MRI for his brain. They've pretty much ruled out anything that seemed dangerous. And he only mentioned it as an aside. I said, well, all right, some of this could be some part of your neck as well. There, SCM attaches behind the ear. It can cause tinnitus. Let's just see. We're going to treat your shoulder and your nerve pain, and some of the things I have to treat for that are going to overlap with your tinnitus. So we'll see how it goes. I started with him face down and worked on the semispinalis capitis, levator scapulae. For the left side, I worked on the upper trap, middle trap, lower trap, levator scapulae right above the inner border of the superior medial border of the scapula, close to where the nerve comes out, that dorsoscapular nerve. I worked on, what else did I add on that one? I think, I treated his infraspinatus because it seemed to be part of his shoulder pain. Infraspinatus, supraspinatus, and teres minor were the originating injury that later, I guess he fell. He already had shoulder problems, and then he fell, and then he started getting this this tingle. So I think what happened was there was some instability already, and then some of the muscles that can compress the thoracic outlet got tight, and now he has this tingle. So the thoracic outlet, people who have not treated it from an orthopedic approach, it is basically the passageway of the three nerves and an artery and a vein through a very small space between the first rib and the clavicle. So the nerves come off of the neck, off of the vertebrae, the cervical vertebrae, like C5 through T1, and they have to pass kind of forward because they want to come out of the armpit and the back of the arm for the radial nerve. So they have to come off of the side of the cervical spine and pass a little bit forward under the clavicle and above the rib, and then they have to go into the armpit area. So the inner two median and the ulnar nerves are going to pass on the inside of the arm, and then the radial nerve kind of goes around to the back and down the triceps, and then it comes around the lateral epicondyle and goes down to the forearm. So the radial nerve was the symptoms he was having. So that's what I was mostly concerned with. And so I did treat like a C5-6 area on his neck, but I'm mostly doing that for semispinalis capitis as well. It wasn't like I was thinking, oh, I have to treat C5-6, but I thought, why skip it? Because there could be some compression there that's causing this. So after the face down, I put him on his side to treat the left side and treat the lat, serratus anterior, and what else did I do on his side? I think that was all I did on his side. And then I said, okay, out of curiosity, I'd like to see what percentage of relief you've gotten so far, because I'm kind of thinking, what if it's that lower trapezius area that's like the main tingle? So I just wanted to see, and after working on this, while he was on his side, I got the neck stuff. I got the middle scalene. I got his levator again in the neck area, like C5 area, because it was still tight when I felt it. And then I treated his SCM, and I did a little trigger point release of the upper trap. Okay, then I retested. So, and I'm going to explain why I did any of those in just a second. And by the way, I'm teaching how to treat neurogenic thoracic outlet from an upper cross syndrome paradigm in Sydney, Australia at the end of March, and also in Barcelona in September. And those dates are on my website at richhazel.com if you're interested. Learning how to treat thoracic outlet is really important for any upper extremity nerve entrapment. So, okay, so we did the roost test again with him after that, and I didn't do any of the front. Like pec minor is so important for thoracic outlet, for neurogenic thoracic outlet. But I wanted to see what was going on. He said it was a little less, but it did come back. The tingle did come back. So then on his back, I treated both heads of the pec major, the sternal and the clavicular heads, and I treated the pec minor. And what else did I do? Face up. I think that might be all I did. And then I had him tested again. And it was much better. It took a little longer for the tingle to come back. And then I said, okay, I'm going for that lower trap. And then so I put him face down. I dry needled his lower trapezius, got some amazing fasciculations. Like they just wanted to jump. And then he had no more tingle. I waited, I don't know, I had him in the roost test for over a minute with no tingle. And then I said, well, what about if you were typing? Can you put your arms out front? No tingle. So I said, okay, if you need to come back, but this looks good. Give it a day to heal, because there's going to be inflammation that can also make those muscles a little too tight and put a little pressure on the thoracic outlet area. But hopefully you're good, and I think he will be good. So I want to talk a little bit about why some of these muscles are important for the thoracic outlet. The two main ones that most people think of and that people know about are the scalenes, the anterior middle scalene and the pec minor. Those are the ones, well, the scalenes attached to the first rib. So when they're short, they're pulling the rib up a little bit, decreasing the space for the nerves as they go through that space between the clavicle and the first rib. And then, of course, the pec minor, because it runs right above those nerves in the artery. So, when the pec minor gets tight, it's tilting the scapula forward and it's putting pressure down in that little passageway, and it can decrease the space for the nerves and the artery, by the way. So, and by the way, if you know somebody who has the thoracic outlet that involves the artery, then they need to go to the doctor ASAP. You don't try to do some acupuncture magic. They should go to the doctor ASAP. So, anyway, for neurogenic thoracic outlet, there's not usually any major weakness of the arm. It's usually a tingle. It's usually something that's causing some numbness or tingling. There could be pain. Obviously, if you think it's too intense, then they should go to the doctor and then come see you when they've been cleared for conservative treatment. So the ones that most people know are the scalenes and the pec minor. What a lot of people don't realize is that there's a whole lot more involved in it. If you know the Yonda upper cross syndrome, you're golden. The pecs and the lats attach on the humerus, and they run right over that nerve bundle. The pec major and the lats have tendons that run right across where that nerve bundle is. So then the pecs and the lats can also do that, and because they're increasing the forward head posture and that anterior tilt of the scapula, then that also decreases the space for the nerves. The forward head posture affects the thoracic outlet as well, by the way. So working with the neck extensors is very important. The trapezius, if you know the anatomy, the trapezius comes over the top and attaches to the clavicle. Remember, the clavicle and the first rib are part of the thoracic outlet. So the clavicle can get depressed by tight traps. I think the lower trap is partially putting a compression on the clavicle, but it's also an upward rotator like the upper trap is. What if it's short because of trigger points and it's putting an upward rotation on the scapula, decreasing the space for the nerves? That's my thinking about how that trigger point in the lower trap causes tingles down the arm. If anyone who's been doing this long enough knows that happens, The lower trap gets trigger points that can cause a nerve pain that goes down the back of the arm. That's the radial nerve. So for whatever reason, if it's an upward rotation or it's a depression of the clavicle, the lower trapezius has a trigger point that does compress slightly the radial nerve and cause a nerve pain or tingle going down the arm. So then the lats, do you know that the lats, while they do not attach to the first rib, the fascia of the lats, when your lat is tight, puts a compressive force on the rib cage and can slightly elevate the ribs and decrease space for that nerve bundle, the brachial plexus. So tight lats, not only does that tendon go across the thoracic outlet area, but tight lats and the fascia from the lats can lift the ribs and decrease that space. So the lats are to be considered for neurogenic thoracic outlet. The levator has a role to play as well, because it does elevate the scapula. The SCM attaches to the clavicle. So a forward head placement from tight SCM can increase or decrease the space for the nerves. So the SCM is part of it. The forward head placement is part of neurogenic thoracic outlet. The Yanda's upper cross syndrome is your roadmap out of neurogenic thoracic outlet. And when you think like this, you give people a good result, like really, really quickly, most of the time. When I first started treating neurogenic thoracic outlet, there was no one that I could ask, like, how do I best treat this? I had to learn a lot from not just reading and studying the anatomy, but just trial and error, like what was helping and what wasn't helping. And one of the things that I knew helped, and I didn't really understand why, was to treat the trigger points in the upper, middle, lower traps and the levator scapulae. The trigger points of the levator scapulae that come off the top of the scapula, right in that middle trap area, seemed to, in many cases, relieve or eliminate this thoracic outlet tingle, especially in a working environment. I'm thinking of other patients that I had where it would tingle when they worked at their desk with their arms out front. They would want to type and their hand would go numb or go tingling. And that really seemed to help. Now, of course, I did have to treat scalenes on these people, middle and sometimes anterior scalenes, but middle scalene seems to be a winner for increasing the space between the rib and the clavicle. So those were always things that I knew to go to. But over time, I've been studying more and trying to really hone in on like the best solution. And what I did for this guy seemed to have made a big shift for him. And I believe it will have resolved the problem. And I gave him some easy doorway stretches for his pec major and his lats, because I really think for him to have his shoulder feel better, have his neck feel better, and to have his neurogenic thoracic outlet stay away, it's all about addressing the upper cross posture and stretching out the pecs and the lats. Now, in the middle of the treatment, after doing the left side of his neck, he said the pulsating tinnitus had decreased or gone away on the left side. So I did treat his right SCM and middle scalene. And then he said it was greatly diminished and maybe even gone, the pulsating. Now, he probably still has a bit of the hiss, but it's not as annoying when it's not that pulsating sort of thing. So I think that the SCM was the winner for the pulsating tinnitus that he had. And I said, if it's better, but you want to see if we can do better, come back and we'll address it more. I'm going to hope that his neurogenic thoracic outlet is resolved, because it was an acute injury that led to it. It wasn't like it's been going on for years. That makes it a little easier, because all I have to do is get him to where his muscles were in elasticity right before the injury. I'm not trying to unravel an extra year or two of upper cross syndrome. So I'm hopeful that he will have had a quick resolution there. But I wanted to talk about neurogenic thoracic outlet. I've done a lot more studying on it, and I'm really good at resolving it on most people, like pretty quickly. So, and it's important because, as you know, I mentioned, it's kind of like a double crush. Thoracic outlet or some minor compression at the thoracic outlet can be that double crush that makes a forearm nerve entrapment worse, like a carpal tunnel or a pronator teres syndrome, or a radial nerve entrapment, radial tunnel. So I just think everyone should know how to assess for it and how to treat it. And it might not be as simple as pec minor and middle scalene. There's more to it. So I just wanted to throw that out there. If you are interested in coming to Sydney or Barcelona, those registrations are on my Instagram at Rich Hazel, and they are, well, on my Linktree, which is on my Instagram, and also on my website at richhazel.com. So, and the Sydney will get recorded. So then, if you can't make it to Sydney, I will not, you're not hurting my feelings. It's not close for a lot of you. That will be recorded, and it will go on Podia. And so then you'll have that whole lecture and the video demos and all of that stuff, just like all the other Podia courses. So that's it for today. And I hope you're having a great weekend. Take care.